see I've gone inside. It's very bright. I'm not actually seeing like upper chest scope. And as I go to the esophagus, you see I'm very close to the esophageal wall, and therefore I don't see any lesion except the very nice vascular features that you see here. And as we go down, when I reach the D junction, what I do is I put my scope into the fundus of the stomach. I'm now in the fundus of the stomach, and I turn see my position. I'm turning my body to the left, putting the scope up like this. The reason why I do this is all the fluid in the fundus I want to aspirate. This patient is independent, but many of our patients for ERCP are not. So this is a very sensitive. Then I come back, I aspirate all the fluid. I'll come back to my original position, which is facing the patient. And as I do that, I just look down. And you can see what I'm doing. The big knob I'll put down. So I make a side wheel scope into an end wheel scope like this, and I'm looking directly right into the pyloric region. Now as I go to the pyloric region, I move my up and down knob straight up and down. The reason is constantly keeping pylorus in the view so that I know I'm getting to the pylorus this way. In the long route a little, and as I approach the pylorus, you can see this is a distorted pylorus because of extrinsic obstruction. So I go to the pylorus, try and see it carefully, and then what I do is, if you can watch my big knob, I'm going to make it straight so that I go through the pyloric opening. Now I'm through the pyloric opening, and I'm looking at the second part of the duodenum. I turn this small knob to the right, fix it here, and then keep going inside till I get into deep into the part, and then I do a very important movement. That's what I want you to notice this. And if the fluoro also can be on, you can see this movement both on fluoro and endoscopy. So can we show both fluoro and endoscopy together? Yeah, you're seeing now? Yeah, if we can have both, but otherwise it's okay. So just look at the fluoroscopy itself, how it's going to see. What we're going to do now is, I'm going to put the big knob up like this, turn my body to the right, and pull the scope out. So these three movements are very important, and as I do this, you'll see the scope which is on the long side becomes a short scope. See this? And all the time I'm visualizing the papilla. And you can see the papilla very nicely now. And if you can get back to the endoscopy image, you can see the papilla. Are you seeing both the images? Naresh, who's there? Yeah.
Now we can see both. Now we can see both. Yes.
Yeah, and you can see the nice position. You can see that my scope is not strictly in the standard ERCP position. That's because of extrinsic impression that is there, which makes it a little more difficult. I'll try and shorten it a little more. The important principle again for those who are starting ERCP is to put your papilla just below the 12 o'clock position. Because I'm using scope, the axis come in such a way that cannulation becomes easy with that below 12 o'clock. So I now in very steady position, and you can see that I move my body a little so that I'm actually facing to the right of the patient, not directly facing the patient. Because if you face the patient directly, the scope slips out. Now for cannulation's sake, I'm using Olympus sphincterotome, clever cut sphincterotome. I never use a cannula, always sphincterotome because the ability to bend it. And also it's preloaded with a guidewire, and I use a thermo-angled guidewire. So standard thermo-angled guidewire and a sphincterotome which can take it.
Sir, just one point. Sir,
yeah.
Whether we use a short scope position or a semi-long position for a very effective cannulation.
So I always use a short position, but if there's altered anatomy, sometimes you have to use a semi-long position.
Thank you, sir.
Now, the problem in this case is hilar obstruction. The lower part is completely narrow, so we won't be able to enter very easily. That's the reason I'm using an angled guidewire, and you can see that the sphincterotome comes.
In fact, if you have been observing carefully, you are having some sort of liquid which is pancreatic juice and no bile.
I think that's a good observation, so that also helps me. So I asked Srinivas to get the wire out, and I just Srinivas the wire out and turn. See what is going to demonstrate. See how it's turning so much. So this is the advantage of an angled thermo. Now we'll go back inside, and what I do is I'll try and selectively go into the bile. Can you get? So this is one technique where you can actually have your wire outside in the beginning itself, so that you can follow the wire in this case because of the difficult cannulation. So this is the area where I'm aiming at, and I'm hoping that the bile comes somewhere here. In this area, 11 o'clock position. Now, just see if we can get the camera. He's bending the sphincterotome a little to give it a more 11 o'clock position, and then he's trying to push it in. So now it seems to have gone into the bile duct.
What Nagi did unconsciously was that he unbored his cannula, papillotome, and straightened it and went inside the bile duct. You can see that once you have the wire going above the scope, you are sure you're in the bile duct.
Yeah.
If it is turning left from the below the scope, you know that you are in the pancreatic duct. And you know, we don't have the luxury in many of these patients to, you know, inject liberally, so he's been using very little.
Very little, yeah. So now I know that I'm at the hilar obstruction, and now we'll ask Srinivas to stop. Manipulate the wire. Very important, don't inject too much, because if you inject too much, you will then land up in. Can you zoom the upper part little? Yeah, now we'll bring back the wire, the thermo wire. Bring back. Now we'll try and see if we can cannulate selectively to go into, now I think it's gone inside. See this? So this is a technique. All these are simple techniques, but if we follow them, your success rates will increase. Now what we'll do is we'll ask Srinivas to inject. Now I'm deep inside, I'm confident. So I'll ask him to inject some contrast, mainly to see the anatomy here. We have an MRCP anatomy, but I want to confirm. Inject. So now we're injecting, and it seems to go to the right. In fact, both are communicating. It's type 2, it's communicating. So this is a good sign for us. Both are communicating with each other. Now at this
Anterior has not come.
wait, I just
The left duct with posterior duct. Left duct with posterior duct is communicating. Right anterior possibly is not.
Our thing is to try and delineate about
Just bring it down a little. Bring them. Yes. That's it.
So you can see the left duct there, the right posterior, right anterior maybe not be separated.
Yeah.
And we'll go down again here. I want to change the wire now. At this point, very important, I want to change to a regular Retrograde 025 wire. Again, very important in ERCP, use only 025 wires, not 035. We'll stop using. And this time I'm using a Retrograde wire, which is quite good in my opinion. And we'll try and do a deep, actually, this is right anterior.
Yeah, there is.
Yeah.
But we have gone with the regular wire in the beginning itself.
Who's speaking?
Yeah, I'm Dr. Ajit.
Ajit. Sorry. Ajit, the reason I always use the angle thermo because I anticipated a lot of difficulty in this case. Because in the hilar obstruction, the lower part of the CBD is completely collapsed. There is some distortion there because the tumor seems to be impacting there. So I anticipate difficulty. But anyway, in all our cases, we use an angled thermo wire. Last time, Ranjit gave me a case of hilar obstruction. It took about 45 minutes to enter into the bile duct. So, I looked at the precedent also. But whatever it is, I advise that all the instances of starting, you start with an angled thermo wire because you see when you twist it, how it twists. The major problem we have in these cases is because it goes into the pancreatic duct all the time. If you twist it, come out, it twists and goes to the bile duct. So always use the thermo. The only disadvantage of that is extra wire to the cost factor, but you can reuse the thermo wire. Okay. Now you see the sphincterotome has come out, and you can see in the sphincterotome there are two parts. A clever cut part, which is actually a plastic sheet around, they don't cut too much, and then you have a bare part, which again, if you can get the external picture, I hope you're getting the external picture. You're getting the outside picture, yeah. See, I'm very relaxed. I'm away from the papilla. I'm using the elevator to take it up the sphincterotome off against the mucosa, and I'm using endoscopic current. And small subtle movements of the body, you see how I can move a body left, right, and so on to change the direction of the knife. I cut up to the edge here, that's nice. So then you can see now free flow of fluid. Now the reason why I did this is bigger cut than normal would be that I'm putting a metal stent. If I put two stents, then I want a wider opening. Now anyway, now we are well placed now. Yeah. So what we'll shift another room before we set up the cholangiopancreatography to see the cholangiopancreatography. Okay? Shift. Okay?
shift to the other room?
Yeah, sure, sir. So we'll be shifting to room number 4.
Yeah.
The normal video is already ready with us.